Hello, my name's Bill Aird from the Blood Project. Today's lecture is going to be on the ABCs of the CBC, that is, the basics of the complete blood count. The lecture is divided into two parts. In the first part, we will discuss the various parameters of the CBC with an emphasis on the red cell indices. In the second part, we will drill down and dissect the pros and cons of considering the hemoglobin versus the hematocrit in patients who deviate from the norm. By the end, you should have a better understanding of how to navigate the CBC and how to leverage it to improve patient care. Of all internal tissues in the human body, blood is the easiest and least invasive to sample. In fact, one could think of the CBC as a liquid biopsy obtained through a simple venipuncture. The CBC is the most commonly ordered clinical laboratory test in the United States. In 2014, for example, over 40 million assays were performed in this country, a number that most certainly has increased since then. The CBC is performed in almost all medical laboratories on a daily basis, providing a cost-effective assessment of a patient's state of health, as well as important clues to the presence of underlying disease. It may also be used for monitoring progression of disease and its response to treatment. The CBC is used to evaluate the cellular components of blood, that is, the white blood cell, the platelet, and the red blood cell. In addition to these cellular elements, blood contains a liquid portion called plasma. Without plasma, blood would be a solid tissue like other organs in the body. Plasma not only allows blood to flow freely, but it also serves to deliver soluble substances around the body. Plasma contains about 90% water, with the remaining 10% being made up of thousands of proteins, ions, dissolved gases, nutrients, as well as waste products. Alterations in the level or function of these components, measured either in serum or plasma, are leveraged for diagnostic purposes in every clinical discipline. For example, cardiologists are interested in circulating levels of lipids to predict risk of coronary artery disease in their patients, as well as the presence of leakage products such as creatine kinase and troponin arising from ischemic heart muscle. Nephrologists routinely assay for urea and creatinine, which are normally excreted by the kidney and build up in the blood in states of renal dysfunction. As a final example, endocrinologists focus on hormones, which use the blood as an information highway to communicate with tissues throughout the body. So if hematology is the study of blood, you are all part-time hematologists, no matter what your clinical interests are. The goal of my talk today is not to have you memorize the various parameters of the CBC. That would not be a very productive use of your time, but rather to build a conceptual framework for approaching the complete blood count. In this lecture, we will focus primarily on red cell parameters. There's more than enough to cover on this subject. And in a future session, we will discuss the white cells and platelets in more detail. Let's begin with a warm-up exercise by considering the following three questions. First, which parameter do you prefer to use when discussing a patient, the hemoglobin or the hematocrit? Why? Are the two values interchangeable? If not, then how do they differ in meaning? Second, of the various red cell indices shown here, which is least useful in daily practice? The MCH, that is the mean corpuscular hemoglobin, the MCHC, the mean corpuscular hemoglobin concentration, or the MCV, the mean cell volume. Which of these can we generally ignore? Now, if you're not familiar with one or more of these parameters, don't worry, we'll cover them all in short order. Finally, of the red cell parameters shown on this slide, which is most highly conserved among mammals? The MCH, the red cell count, the MCV, or the hemoglobin? You may be wondering why I'm bothering to bring up comparative physiology in a clinical talk. But one of my goals today is to try to convince you that a comparative perspective provides a powerful tool for approaching and understanding the human condition. So here's the CBC in all of its glory, as it is presented to healthcare providers at my hospital. While there may be some subtle variations between labs and institutions, this is a fairly standard panel. Flanking one end is the white cell count. Flanking the other end is the platelet count. These cells are not drawn to scale. The platelet is about 1/10 the size of the red cell, and the red cell in turn is smaller than the vast majority of white cells. The remainder of the CBC, all these numbers in the middle here, is all about the red cell. How many, how big, how well hemoglobinized. This panel of red cell markers, called the hemogram, is rich in information. It can tell really important stories about our patients, if only we can train ourselves to listen. These 10 parameters, as overwhelming as they feel to us, actually pale in comparison to the number of variables generated by today's automated counters. A single drop of blood from a patient can yield close to 40 parameter values, all in a matter of seconds, most of which are withheld from the practicing physician and used for research purposes only. For example, here we see a screen capture of platelet parameters that include not only the platelet count, which is a staple of the CBC, but also the mean platelet volume, or MPV, which is made available by some but not all labs, as well as the platelet distribution width, the PDW, and the platelet crit, the PCT, two values which never see the light of day, at least clinically. Modern-day automated counters have come a long way since the original Coulter counter hit the market in the 1950s. The Coulter principle uses electric current to determine the count and size of particles, or cells, traversing a narrow opening or aperture. Today's instruments still rely on the Coulter principle, but they have also been equipped with a Star Wars-worthy outfit of lasers, flow cytometers, and spectrophotometers, all which allow for a far more detailed or granular evaluation of a patient's blood. Now, behind the scenes in the hematology lab, technicians are highly trained not only to perform a CBC on your patient, but also to recognize and react to flags that are generated by the instrument, to confirm certain findings with a peripheral blood smear, and to carry out performance validation and quality control measurements day in and day out. Thanks to their tireless service, we as physicians caring for the patient on the front end are provided with an expertly vetted and distilled panel of numbers that are at once accurate and reliable. Let's return to the CBC as we recognize it. The white cell count represents the total concentration of all circulating leukocytes in the blood. A normal count in adults is between 4 and 11. 4 and 11 what? Well, some of us might say 4 to 11 million per milliliter of blood, or 4 to 11,000 per microliter. But if we go with SI units, we would say 4 to 11 times 10 to the 9th per liter, that is 4 to 11 billion white cells per liter of blood. Numbers this large are hard to grasp, so consider this comparison. If we were to stack 1 billion pennies, they would fill the equivalent of 5 school buses, all contained within a single 1-liter bottle of water, as if that's possible. The total white cell count represents the sum of the number of different types of white cells. There are 5 such subsets: neutrophils, which provide protection against microbes; monocytes, which play important roles of phagocytosis and the innate immune response; lymphocytes, which are involved in the acquired immune response; eosinophils, which play a role in the body's immune response to parasitic infections; and basophils, which protect against a wide variety of infectious agents. So, a total white cell count of 7 times 10 to the 9th per liter may reflect, for example, 4.6 times 10 to the 9th per liter neutrophils, 1.4 monocytes, 1.0 lymphocytes, 0.02 eosinophils, and 0.01 basophils. Such a division or separation of the total white cell count into its constitutive parts is called the 5-part white cell differential. Why should we care about the differential? Because any deviation from the normal range of these subset counts has important clinical implications that vary according to the cell lineage involved. For example, an elevation in the neutrophil count, or neutrophilia, is associated with infections, stress, smoking, and inflammation, among other conditions. Whereas an elevation in the eosinophil count, so-called eosinophilia, is associated with allergies, infections with worms, and certain drugs or medications. So just as it would be unproductive to refer to a patient with increased white cell count or platelet count as having simply a, quotes, cytosis, without defining which cell type is increased in number. Using the term leukocytosis without qualifying the white cell subset involved tells only part of the story. So in this example, we would talk about a patient with leukocytosis manifested by or reflective of neutrophilia. Let me just say two more things about the white cell differential. First, in most institutions, you have to order it separately from the CBC. Don't forget to check off the box. The same, by the way, is true of the reticulocyte count. Like the white cell differential, retics are typically measured by the same automated counters that generate the CBC, but they are not considered a part of the routine CBC and need to be requested separately. Second, the results are often expressed in two forms, as a percentage of the total white cell count and as absolute counts. As a general rule of thumb, whenever you are provided with percentages and absolute numbers in hematology, ignore the percentage and focus on the absolute value. Let's look at two examples of how the percentage can be misleading. First, consider the patient who has received large doses of chemotherapy and has a dangerously low white cell count of 0.1 times 10 to the 9th per liter. 98% of these cells are neutrophils. That sounds pretty good, right? But 98% of next to nothing gives you, well, next to nothing. With an absolute neutrophil count, or ANC, this low, the patient is at high risk for developing a lethal infection. Now consider the patient with chronic lymphocytic leukemia, or CLL, whose total white cell count is 100 times 10 to the 9th per liter. The vast majority of their circulating leukocytes are lymphocytes. The neutrophils comprise a tiny fraction, a mere 2% in this example, but the absolute neutrophil count, or ANC, is perfectly normal, and that's what matters. At the opposite end of the ledger is the platelet count. Like the white cell count, the platelet count is expressed in billions or 10 to the 9th per liter, with normal counts ranging between 150 and 450. By contrast, the red cell count is 3 orders of magnitude higher, logging in at trillions or 10 to the 12th per liter. In other words, there are about 1,000 red cells for every circulating white blood cell. To put the number trillion into perspective, we are no longer filling school buses with pennies, but rather an entire several-story office building spanning the length of a football field. For purposes of today's talk, we are going to ignore the white cell and platelet count. As I mentioned, these are topics for another day. And we are going to focus on the red cell parameters, the so-called hemogram. I will briefly discuss each of these parameters in turn, moving across the panel from left to right. First up is the red cell count, a parameter that I bet most of you have never seriously considered. Have you ever wondered why we routinely refer to a patient's platelet count and white cell count, yet use the hemoglobin and the hematocrit instead of the red cell count to refer to the red cell mass? We will return to this question a little later. One exception where the red cell count may be helpful on occasion is for differentiating between iron deficiency anemia and thalassemia minor, both of which are characterized by small red cells or microcytosis. The red cell count tends to be higher in thalassemia because the bone marrow, unencumbered by nutritional deficiency, is able to compensate for the small size of the red cell by producing more of them, and thereby maintain a normal or near normal hematocrit. But we have better ways now of making the distinction between thalassemia and iron deficiency anemia, including iron indices and the hemoglobin electrophoresis. So really, for all intents and purposes, we can ignore the red cell count and in doing so, simplify the hemogram. Next we get to the meat of the hemogram, the hemoglobin and the hematocrit. The hemoglobin, all of which is packaged inside red cells, unless they are hemolyzing, is a concentration expressed in grams per deciliter of whole blood. The normal hemoglobin level for males is 14 to 17 grams per deciliter. That for females is between 12 and 16 grams per deciliter. You might ask, why do we talk about cell counts in liters of whole blood, yet hemoglobin in 1/10 of that volume, in deciliters? And the answer really is one of tradition. While much of the world reports hemoglobin as weight per liter, in keeping with the International System of Unit, or SI unit, which keeps things simple and internally consistent, the United States has stubbornly held on to the deciliter convention. When you read the literature, you will frequently see both values reported. Because the examples of CBCs that I'm showing in this talk, like the one on the current slide, report the hemoglobin in grams per deciliter, I will stick with these units, or this convention, for the time being. Fortunately, toggling between the two systems is a simple matter of multiplying or dividing by a factor of 10. The hematocrit is the fractional volume of whole blood that is composed of red cells. Normal levels for men range from 41 to 50%. For women, between 36 and 44%. The hematocrit can be directly measured by drawing blood into a tube containing an anticoagulant, spinning the blood sample in a centrifuge so that the red cells fall to the bottom and the plasma layers out on the top, and then measuring the relative heights of the plasma and red cell columns with the tube vertically positioned. In this case, the red cells occupy about 37% of the blood volume, with plasma accounting for the remainder. We're going to leave the hemoglobin and hematocrit for the moment and look at the remaining parameters, which we call the red cell indices. These describe the size and hemoglobin content and concentration of red cells. The reason we need to care about the red cell indices is that they hold important diagnostic clues, especially when it comes to sorting out the many causes of anemia. First up is the mean cell volume, or MCV, reported in fentiliters. A fentiliter is a really tiny number, 10 to the minus 15 liters. The normal range for the MCV is between 80 and 100 fentiliters. These are easy numbers to memorize, and I would encourage you to do so because the MCV is routinely used to characterize anemia. You shouldn't have to look up the numbers every time you approach a patient with a low hemoglobin. So once again, 80 to 100. 80 to 100. Cells that fall below this range are called microcytes. Those that are larger than normal are termed macrocytes. When a population of red cells are on average smaller than normal, the condition or state is called microcytosis. And conversely, when the average size is larger than normal, we use the term macrocytosis. Microcytosis and macrocytosis can occur with or without anemia. In cases where the hemoglobin is normal, we use the terms isolated microcytosis or isolated macrocytosis. The MCV is the most clinically meaningful of the red cell indices because it represents the first branch point in the diagnostic algorithm for anemia. Anemia may be microcytic, normocytic, or macrocytic. Each has its own unique differential diagnosis. We will return to this at the end of part 2 of the lecture. Next, we arrive at the MCH and the MCHC. Coming back to an earlier question, which of these two parameters do you think is more clinically useful? Let's think this through. The MCH is the average weight of hemoglobin contained within a single red cell, measured in picograms, 10 to the minus 12 grams, another tiny number. If we were to lyse or break open a red cell and pour out all the hemoglobin, like a little bag of sugar or Splenda, onto a weighing scale, and then average the weight across many red cells, that gives you the MCH. Another way to think about the MCH is in 2 dimensions. Consider a schematic of the red cell. Note that I have drawn this cell in 2 colors. A thick perimeter of red, which represents hemoglobin, surrounding a central hemoglobin-free zone of white. This white core represents the region of central pallor seen in red cells on a peripheral smear. Because of the biconcave shape of the red cell, with its super thin center, the hemoglobin gets pushed out to the perimeter of the cell when a smear is made, creating the illusion of a hemoglobin-free center. Normally, the diameter of the zone of central pallor represents about 1/3 the diameter of the cell. To obtain the equivalent of the MCH, I want to add up all the red color in the cell and put a number to it. Now, if you're like me, I'm not very good at calculating the area of a thick red ring, so let's imagine removing the area of red and rearranging it into a rectangle, which we can readily quantify using width and height dimensions. In this scheme, the greater the area of red, the more hemoglobin contained within the red cell, and the higher the MCH. As you might imagine, the MCH tracks with the MCV. If we hold the central pallor constant at 1/3 of the cell diameter, that is, we assume a normal hemoglobin concentration, then the larger the cell, the more hemoglobin is contained inside. If we return to our thought experiment of extracting out the red color and rearranging it into a rectangular shape, then the size or area of the rectangle increases as the cell gets bigger. In fact, some argue that the MCH can be used as a surrogate marker for the MCV. The problem with that assumption is that the MCH varies not only with cell size, but also with the concentration of hemoglobin inside the cell. For example, if we hold the size constant and pack in more hemoglobin, as shown here, that is, we increase the mean corpuscular hemoglobin concentration, then the MCH also increases. That's not to say that the MCH does not come in handy on occasion. So check this out. When blood is drawn and allowed to sit around for hours to days, red cells take on water and swell. As a result, the MCV artificially increases and the MCHC decreases. That is, the hemoglobin concentration drops as the cell becomes diluted with water. But the hemoglobin hasn't gone anywhere. The MCH, the weight of the red cell in hemoglobin, is unchanged. So, when astronauts on the space station want to carry out a study on the effects of space travel on the hematological system, they draw blood at defined time points and store it at 4 degrees Celsius for however long they are in orbit. Once they return to Earth, where they have access to an automated counter, they control for the inevitable time-dependent swelling of cells by using the MCH as a marker for the MCV. But for us mere mortals, the MCH really doesn't add anything in daily practice. It does not tell us anything that we can't glean from the MCV or the MCHC. And it's nowhere to be found on algorithms for the diagnosis of anemia. In fact, we can safely ignore it altogether. It's nothing more than a distraction, and if anything creates unnecessary confusion with the MCHC, which is a vital red cell index. As we've already alluded to, the MCHC is a measure of the weight of hemoglobin per volume of red cells, and is reported in grams per deciliter. You will note that the MCHC and hemoglobin concentration are both expressed as grams of hemoglobin per deciliter. So what's the difference? Well, hemoglobin is expressed as grams per deciliter of whole blood, while the MCHC is expressed as grams per deciliter of red blood cells. To reiterate then, the MCH is expendable, while the MCHC is, well, it's a keeper. How can you remember this? Think of the acronym with the extra letter as being the important one. A normal red cell with its 1/3 central pallor has a hemoglobin concentration of 32 to 36 grams per deciliter. This is another number range that is worth committing to memory because, like the MCV, the MCHC provides important clues when considering the differential diagnosis of anemia. It's an easy range, 32 to 36. 32 to 36. So now we have two ranges to memorize. The MCV, 80 to 100, right? You remember that? And the MCHC, 32 to 36. Cells with lower than normal MCHC are termed hypochromic cells. Cells with higher than normal concentration of hemoglobin, while technically termed hyperchromic, are more commonly referred to as spherocytes. Let's come back to the thought experiment of extracting hemoglobin material from the two-dimensional red cell and rearranging it as a rectangle. To determine the MCHC, it's not enough to simply measure the area of red color. That gives you the equivalent of the MCH. What is important is the ratio of the red color to the entire area of the cell, that is, red and white color combined. So if I draw two rectangular cells of increasing size, as long as the ratio of white color to white plus red remains at 1/3, then the MCH is constant across samples. What is changing is the MCH, but that's only because the cell, and therefore the area of red color, is getting larger. Let's flip over one of these rectangles. Do you see what I see? We have just generated something kind of analogous to the hematocrit of a single red cell. It's as though we have taken the contents of the cell, spun them in some imaginary nano or femtofuge, with the hemoglobin settling on the bottom and the intracellular fluid layering on the top. Pretty cool, right? Here's another thought experiment for you. Consider that planet Earth is one giant red cell. Its inner hemoglobin-free core comprises 1/3 of the volume of the cell. The rest is made of hemoglobin. What is the MCH? And what is the MCHC of this insanely large cell? You will note that I'm using the terms MCH and MCHC loosely to characterize a single cell, when in fact they are used to describe a population of cells, but I think you get the drift. If you guessed that the MCH would be astronomically high and the MCHC perfectly normal relative to a human red cell, you are absolutely right. Now we come to a parameter that's less well understood, the red cell distribution width, or the RDW. In this measurement, the size, or volume, of millions of individual red cells are plotted on a graph. In normal situations, the graph follows a bell-shaped curve with normal variation generated by biological noise around the mean, or mean cell volume. The RDW expresses the width of this variation. When there is increased variation in red cell size, as shown on the schematics of peripheral smears at the top here, the width of the curve and therefore the RDW increase. We call this increased variation in red cell size, whether diameter or volume, anisocytosis. Here's a real example of a peripheral smear showing higher than normal variation in red cell size as appreciated by clear-cut differences in cell diameter. One reason the RDW is so important to consider is that the MCV, as shown on the right schematic, may be normal in the presence of two different populations of cells, one small, the other large. This may be seen in several clinical scenarios, including the concomitant presence of iron deficiency and pernicious anemia, or, as another example, in a patient with thalassemia and liver disease. So before concluding that a normal MCV is representative of a single population of cells, check the RDW. There are two ways of measuring the RDW. The RDW-CV, or coefficient of variation, and the RDW-SD, or standard deviation. I will not get into the specifics of how these two parameters are calculated and how they differ from each other. We'll cover that in a separate session, but let me just point out that the RDW-CV is inversely correlated with the MCV, so that it becomes unnecessarily skewed in cases of microcytosis and macrocytosis. For that reason, I prefer to use the RDW-SD, with a value of 42 being considered normal. Here is the stripped-down version of the CBC in which we have removed the red cell count, the mean corpuscular hemoglobin, and the RDW-CV. Now, as we will see in part 2, we can do even more trimming. But for now, let's end with some take-home points. First, remember that the CBC interrogates the cellular component of blood. It is concerned with plasma only insofar as the volume of plasma affects the concentration of cell number or hemoglobin weight per liter of whole blood. But it does not provide any information about the substances contained within plasma. Other assays, whether chemistry, microbiology, or coagulation, are needed to characterize the liquid fraction of blood. Second, the white cell count is a good start, but don't forget to drill down with the differential, especially if the white cell count is abnormally high or low. But also recognize that a normal white cell count can mask a significant abnormality in one of the cell lineages. You won't know unless you check. Third, ignore the red cell count unless you are in more advanced training. The information yield is simply too low to justify serious consideration on your part. Fourth, forget the MCH and focus on the MCHC. And finally, if you're offered two RDW results, choose one and stick with it. I like the RDW-SD, but you may prefer the RDW-CV. That's okay. Either is acceptable, but to consider both is overkill. That ends part 1 of our lecture on the CBC. In part 2, we will discuss the hemoglobin and the hematocrit in more detail.